chairs, Dr. Douglas and Dr. Russo, although I bet they're well known to many of you on this webinar right now. And then I'll turn the program over to Dr. Russo, who will walk us through today's program. Dr. Douglas, I'm going to start with, since she's not moderating this one today. I'm going to start with Dr. Douglas. She's an associate professor of emergency medicine at our GW School of Medicine and Health Sciences and the Global Health Institute at the Milken Institute School of Public Health. Her research interests are on international emergency medical systems, of course, but also on training programs to develop with an emphasis on sustainability, workforce development, cost effectiveness, and effective educational interventions to assist developing nations develop their workforce. She focuses on the global impact of road traffic injuries and implications for emergency medical systems development. She has a really extensive experience with international medical programs and policy initiatives, including substantial programs in India, Saudi Arabia, Zambia, Turkey, Ethiopia, and Peru. In addition, she serves as the Global Emergency Section Chief in the Department of Emergency Medicine here at GW. Moving on to Dr. Russo, who I mentioned is chairing this webinar today. Dr. Russo is a neurosurgeon who trained here at GW and then went on and had a remarkable career as a clinical neurosurgeon with clinical expertise in skull-based surgery, stereotactic radiosurgery, and traumatic brain injury. In the last decade or so, I'm going to say, she's really stepped into global surgery as a true passion and has joined many international efforts and as a leader, including the Foundation for International Education in Neurosurgery and Think First, the International Head and Spine Injury Prevention Program. She right now is the chair of the board of the directors for the Global Alliance for Surgery, Obstetrics, and Trauma and Anesthesia, commonly known as the G4 Alliance, a real powerhouse in enhancing the visible need for global health initiatives and prioritizing that work and implementing that work. She is a prolific author with over 300 peer-reviewed publications and serves as in a number of leadership roles in global health initiatives, including the Barrows Institute in Nevada. No, in Arizona, the Barrows Institute. Yes, got it. She's the co-founder of the Global Alliance for the Prevention of Spina Bifida, F, which successfully passed a World Health Assembly resolution and is working with member states of the World Health Organization to eliminate spina bifida with readily available tools and methods. With that introduction and knowing that our group has grown to almost 50 participants, it's fabulous. I'm going to turn this program over to you, Dr. Russo, and I thank you and Dr. Douglas and all those who are participating presently and over these years to come for their important work in this really wonderful effort. Thank you. All yours. Hold on one second.
Thank you very much, Dean Bass, both for your kind introduction and for your support in this effort and over the years. Well, welcome, everybody. We are absolutely delighted to be launching this inaugural series, the first webinar for the GW Global Clinical Care Alliance. And I'm deeply honored to be moderating it and really proud and excited to have my colleagues in the Department of Neurosurgery, both here and abroad, be part of this presentation to you today on innovations in global neurosurgical and surgical education. Couple disclosures. There are no financial disclosures. I am the chairman of the board of directors of an NGO called the G4 Alliance, which Dean Bass mentioned. Dr. Donoho, who will be speaking shortly, is also the chairman of the board of directors of an NGO, Surgical Data Science Collective, which he'll be discussing today. Thank you to our dean, to our communications directors and colleagues at both the GW MFA and the GW Med School for developing our webpage, which you see here for the GW Global Clinical Care Alliance. So please check it out, and we will be building that out with more collaborators and more activities in the coming weeks and months ahead. So as mentioned, this is the inaugural webinar series. The next one will be on December 4th and will be chaired by my co-founder and colleague, Kate Douglas, who will, and you can see the details there. We'll mention this again at the end of today's presentation. And we anticipate these webinars to be quarterly in the year ahead. You can register at that QR code. All right, so to introduce our panelists today, in addition to myself, we'll have Tim Singer, our resident in neurosurgery here at GW, who is also a fellow with the Surgical Data Science Collective, assistant professor of neurosurgery from Children's Hospital. My partner and the co-founder of Surgical Data Science Collective is Dan Donoho. And then our good friends and colleagues from the Muhimbili Orthopedic Institute, which, yes, does a considerable amount of neurosurgery, in Dar es Salaam, Othman Wanin, who is the president of the Tanzanian Neurosurgical Society, and Hamisi Shabani, expert pediatric neurosurgeon, consultant also at Muhimbili in Dar es Salaam, and co-chairs a committee with me in the World Federation of Neurosurgical Societies. And with that, I'd like to welcome Tim Singer to the next part of the presentation.
Good afternoon, everyone. It's wonderful to be able to join you for this, and thank you all for your enthusiasm for building the global health platform here at GW. And of course, thank you to Dean Bass for her support. Each year, the World Health Assembly, which is the policy arm of the World Health Organization, meets to draft their upcoming global policy goals. This past year, Resolution 76.2 called for the universal access to eco services for all. ECO stands for emergency, critical, and operative care. The idea here is for every nation on the planet to have a coordinated plan that is nationally run to allow for access to procedural care. This is meant to promote the delivery of integrated services amongst these different specialties, whether it's emergency medicine or neurosurgery, as well as anesthesia, obstetrics, and critical care. Finally, this is meant to help protect in disaster situations, which are obviously part of access to emergency care, but also something that we all continuously contend with in the midst of our growing climate environment. As many of you are familiar, more than 5 billion people across the globe lack access to eco services. That's 5 billion with a B. Every year, more than 300 million surgical procedures are performed globally, but just 6% of those are in low and middle income countries, the poorest countries across the globe. Because of this tremendous access gap, which was well characterized and thoroughly detailed by John Mira and the group that led the Lancet Global Surgery Commission in 2015, we have an understanding of what is the landscape for access to eco services, as well as some insight into what is the gaps that need to be overcome. It's also worth noting that every year, more than 33 million people face catastrophic health expenditures due to their lack of access to essential surgical services. What does this gap look like within neurosurgery? And that gap is something that is continuously well studied as the world of global neurosurgery grows, and GW has been central to that growth, we're proud to say. This paper, published just this past summer by Gupta et al. In the Journal of Neurosurgery, which is one of the leading journals in our field, characterizes in the left-hand graph the current global neurosurgical workforce, which shows that we in the United States have amongst the highest density of neurosurgeons for our population, though we certainly still have shortages in care. In the middle graph, it demonstrates the access to essential neurosurgical technology, whether it's angiography, microscopes, endoscopes, all the essential tools of neurosurgery by income of country. And in the right-hand plot, we see how the access to neurosurgical services by neurosurgical workforce has changed by global region. With this growth, we're seeing that gaps in neurosurgical care are beginning to close, but obviously huge disparities persist in access that we must continue to help address. And that's the goal of our collaboration with our friends in Tanzania. As many of you know, AI has helped transform health systems globally already and is continuing to do so. I like to reference a study done by a couple of friends where they ran different consent forms through AI algorithms and were able to adjust them to make them reading level appropriate. The point being that there are all kinds of applications of this new technology that we can use to increase access to care as well as surgical technology. And what I'm excited to talk about today, along with Dr. Donoho, is how we're doing analysis of surgical video from our colleagues abroad to help improve understanding of surgical technique and ultimately to help improve surgical training, which is meant to have a downstream benefit for surgical access to care. And here are just a couple of recent references from the global neurosurgical or global surgical literature, as well as from the American College of Surgeons, talking about how these changes in technology can ultimately improve access to care. So we aim to mobilize innovations in surgical education to address access gaps in eco-services for neurosurgery patients globally. And that's going to be done between our site here, of course, with the Surgical Data Science Collective that I mentioned, and our friends in Tanzania. So I'm pleased to turn it over to Dr. Othman, who will talk about the neurosurgical landscape in Tanzania for some background.
Thank you very much, Tim. And I'm very pleased to be here and to present on our side from Tanzania. I'm Dr. Othman Kiloloma, the neurosurgeon and president of Tanzanian Neurosurgical Society. I'll pass through on demographic characteristics of Tanzania. Tanzania is quite a big country. Please, next slide. With populations of around 61 million people. This is according to the census of 2022. With a population density of 65.22 per square kilometer. It has reasonably big area, which is almost 94,000 square kilometer, which is 30th biggest country in the world. With a GDP quite very low of USD 76.5 total billion, which is 76 in the world, and per capita income is extremely low, with USD 1,245, which is 64th in the world. But one thing to note is a country with a very high fertility rate of 4.7 births per woman. That means every family, they have about 4 to 5 kids in Tanzania, with a very low health expenditure, which is about 7 to 8% of the total national budget. We should not know that country in Africa, they pass Abuja declarations on which they have to spend 15% of their total budget for health expenditure. That dream has never occurred to many countries, including Tanzania. I think it's only Rwanda which have passed that. If we look at the life expectancy in Tanzania from birth, you can find that there is improvement by almost 12.5 years, on which in year 2000, the life expectancy in Tanzania was 45 years. But in 2021, life expectancy is around 58 years. And it keeps improving due to access of most of the improvement on the health structures of the country and sanitations and other things. But it goes all in all also in other parts of Africa, in which life expectancy has improved by 9.3 years, from 45 years to 55.2 years in the year 2021. If you look at the age distributions of Tanzania, which is completely different from the age distribution in first world countries like Japan, China, and maybe USA, we have a lot of middle-aged people, which contributed about 62% of the total population, and a very few geriatrics above 60 years. They are quite about 2%. But with increased birth rate, which we have noted of 4.7, so we have a lot of kids from 0 to 14 years. So if you look at these characteristics, it's good also to look at the neurosurgical distributions in the country. You can find that we have 7 centers, next slide, 7 centers in the country. And all of these are on the eastern part and the central part of the country. We have Muhimbili, Benjamin Mkapa, Mbeya, which are dotted blue on the map, which are almost on the northern, mid, and the eastern part of the country, but we are lacking services to those which are located on the western part and southern part of the country. And even though we call them centers, but the neurosurgical workforce is quite depleted. We have a total of 27 neurosurgeons in Tanzania. So some centers, they have only one neurosurgeon. When he's sick or go to the leave, there is no anybody to take care of this patient. So among those 27 neurosurgeons in a population of 61 million people, you can find that one neurosurgeons treat an average of 2.7 million populations in Tanzania, which is the figure quite far away from the recommended ratio of one neurosurgeon to treat 100,000 population. The structure is almost the same, not only in Tanzania, but also in other parts of the world. If you look at the total number of neurosurgeons in Africa, next slide, please. Total number of neurosurgeons in Africa, you can find that they're quite much more or less compared to the total number of neurosurgeons in other parts of the world. This is a simple example. Africa continent has a population of 1.4 billion people, while Japan has a total population of 125 million people. But look at the alarming figures of neurosurgeons available. In Africa, where there is only 2,000 in 1.4 billion population, but Japan, they have 125 million, which is quite very high number compared to that, compared to the size of the country, populations, but as well as the number of neurosurgeons. Disparity, I believe, is quite unacceptable if we look at the reasonable way on how we can save our people. If you look at the disease burden which we suffer in my country, we don't have a registered national data registry so far. We don't have a national data registry. So what I can say is from the hospital survey, but we as a neurosurgical society, which is quite new, we're establishing with the coordination of the Ministry of Health, a national data survey. But from the hospital data, we see almost 2/3 of the patients admitted are cases of trauma. 2/3 of the total admissions which we receive, and mainly are young populations in working groups of the country. And the reason why, because most of them are involved in road traffic accidents, and the main reasons, we use motorbike as a means of public transport from one point to another because it's cheaper, faster, and quicker. And we see a lot of accidents, which is unacceptable in any way. We see tumors of the brain and spine, okay, which accounts about 0.2% of the total, and we see them on late stage, not as early as what we can see, because the health-seeking behavior is completely different. They have to pass through witch doctors, religious leaders, and then they come to us on the late stage. Nowadays, we have seen a pandemic, I can say it's sort of a surge of stroke cases. What's more alarming, we see them in younger age group between the age of 20 to 40 years, which is completely different from the previous figures which we had, on which the patients were above 50 years and above. But also we have an alarming number of hydrocephalus and spina bifida in the country because of lack of, despite effort taken, but on which we have followed fortifications in the year 2012, the police of the country, but the practice is not really in place. We are still doing surveillance on that, but we have a lot of cases there, neuro kids. With all deficit which we have, we've built collaborations on how to cover these gaps. And one of them is neurosurgical training. This is a pathways of neurosurgical training. One was the MSc programs on which we use general surgeons. Then they go to do neurosurgeons in the country, but as well as outside the country on different countries like Japan, South Africa, India, Korea, Southern Korea, and others. And they come back and awarded the MSc neurosurgery program. The second is called SEXA program. This is a College of Surgeons of East, Central, and Southern Africa, on which we train neurosurgeons for 6 years. And we have enough number of neurosurgeons in the country. We are establishing this year the MED neurosurgery program, on which somebody can be trained, a resident can be trained in our country, and they go abroad at least for a period of 6 months to cover an area on which we don't cover in our neurosurgical program. Also, we have fellowship programs on different parts of the world, but also we have the PNNT. This is Pioneer Neuroscience Nurses Training, on which with the aim of training trainer of trainers. As you understand, neurosurgery is not one-man show. We need the assistance of neurocritical care nurses, neuroradiologists, neuroanesthesiologists, and others. So we have started this program, and we are very thankful for Professor Gail and WFNS for working on this, and we have already certified 5 PNNT nurses in Tanzania. So we have an international partnership. The main partnership, which you can see here, mainly is from North to South partnership. We have a partnership between Tanzania and G4 Alliance through Mercy Ships, Smile Training, SOTA Convoys, and others, on which assist on covering the gap of neurosurgical delivery in the country. PNNT, as I said, but also a partnership with Weill Cornell in New York, and Professor Roger Hatto and Moy, on which we have a neurotrauma every year for the brain and spine, and we have published quite a number of researches on that. We have also partnership with University of Colorado with Muhimbili Orthopedic Institute, where I work there as a neurosurgeon, especially on neurovascular disorders and neuro-oncology. Also, we have our colleague in Benjamin Mkapa. This is a hospital located in the center of Tanzania with Japan, especially for neuroendovascular treatment. We are thankful also for the Uganda Cure International for NeuroKids, on which currently we have a number of neurosurgeons trained there, and for endoscopic third ventriculostomy and CPC. And the number keep growing up, as well as surveillance. But also we have partnership with Barrow Neurological Institute with KCMC. Again, thanks for Professor Gail and other colleagues for these collaborations. But also there is a collaborations in the country in HIDOM, even though it's low volume, on Madaktari Africa, on which they train general surgeons to do neurosurgical procedures in rural areas. I'm saying this is a deep rural areas in HIDOM, Manyara district. So this is the kind of collaborations which we have, but mainly are north-south collaborations, which we have to think about to have south-south collaboration in the near future. So with this, I'd like to, unfortunately, my colleague, Dr. Hamisi Shabani, had the internet program. But before going to that, I'd like to give some key messages about Tanzania. It's a big country, but with a very small neurosurgical workforce, but with a very high fertility rate, and all we understand the neurosurgical disease burden in neurokids, with a very low budgetary allocation for health, but also expertise on new surgical techniques and knowledge are quite minimal, because once you are trained and qualified, it's quite difficult for you to leave and go outside to train more for this neurosurgical activity. But also we have diversity of training programs. We have neurosurgeons coming from different parts of the world. They're coming from Japan, South Africa, India, USA, and each has his own way of doing things, following what has been trained by his own mentors. So this also is quite a problem which we face, and we want to find a way where we can move through the same goal. And as a Tanzanian Neurosurgical Society, we are working on that. As I said, my colleague, Dr. Hamisi Shabani, who supports our pediatric neuroscience, unfortunately not here today, is the head of our pediatric neuroscience and a pioneer, a key person for ETV and CPC in our center. I would like to present the slides on harmonization of optimal surgery care for pediatric neurosurgery. Next
Dr.
slide,
Othman,
please.
may I bother you for 1 minute? I believe Dr. Shabani may have solved his issue. So can we see if it's
Okay.
possible for him to turn on his video and potentially present?
Okay, I thought. So maybe I should talk a little bit. Dr. Shabani, Mrs. Shabani is my senior, has been in the department for quite a long time, quite a valuable asset in our unit, a pediatric neurosurgeons, and has a high volume data. Welcome, Dr. Shabani.
Okay. It seems like Dr. Shabani might not be in the best place, so we'll see
Yeah.
if he can do it. This would be excellent. Otherwise, no worries.
He is there. I can see him. I can see him.
Hello, Dr. Shabani. Can you hear us?
Yes, hello.
Just let us know when you need me to advance slides.
Yeah, let's move on. My task was just to talk on only on 2 slides about the hydrocephalus spina bifida project in Tanzania. Actually, it started as a rudimentary project for many years, and it became official project at MOI in 2005. And one of the big milestones which we had was fortification of the national legislation on the flower fortification, which came into place in 2012 and been sponsored by World Bank. And then we published our first paper, which showed the magnitude of birth defects in Dar es Salaam, which is not far from the world statistics, 3 per 1,000 live births. And then we introduced the now on the second slide, please. Second slide. We introduced the endoscopic ventriculostomy and choroid plexus cauterization using the flexible ETV in Tanzania. We were the first pioneers. I was one of the very young neurosurgeon who got trained in Mbale, Uganda, the Benjamin Wolf Center, where he introduced this technique using the flexible endoscope. And I came back to Muhimbili Orthopedic Institute. We started this, and we created a very big database of hydrocephalus spina bifida. Currently, we are boasting of 4,000 plus cases in our list. And not only that, we trained our young neurosurgeons, and we managed to recruit 4 centers, which now are performing exactly what I'm doing. These are Bugando, KSMC, and Haydom, Arusha Lutheran Center. So these are the biggest milestone which we have maintained. We have robust equipment and instruments, which we can share the videos. We have a local network of QR International, because I was sponsored by the QR International. So we have a local network where we discuss these cases once every 3 months. We keep on improving our techniques, and now currently even the machine can be used for other uses, not only performing ETV CPC for hydrocephalus. We are also moving forward to use this instrument to do tumor biopsies and tumor excisions using the flexible scope. So this is what I wanted to share with regard to what we are doing with this project. By the way, the other information which I need to share with the colleagues from the high-income countries, you know, the VP shunt is still a standard goal for management of hydrocephalus, but taking the fact that there's very high risk of infection following VP shunt infection, and VP shunt incision. And this becomes a surgical emergency. And this now the resources cannot afford that kind of an emergency. That's why it's really important now that we train our surgeons at low and middle income countries to perform ETV and CPC, because this one is free from those complications. Thank you.
Wonderful. Thank you so much for a wonderful talk. And I think I'll follow up directly from both of your comments and share a little bit about what we're going to do in this collaboration, how we're going to use technology to improve and better understand surgical care. From my perspective, I'm a faculty here at George Washington University and Children's Hospital, and the founder of a nonprofit charity called the Surgical Data Science Collective. So I think the primary question is, how do we actually harmonize surgical care across all of these areas? And one initial question might be, why do we think that there is any data in the operating room? Why do we think that there's anything we can do that's more than what we've done? So for those of you who haven't seen an operating room, I wanted to enclose a slide here. And admittedly, this is perhaps from the ivoryest of towers, but many of neurosurgical operating rooms and procedures contain the same core equipments, which includes screens, cameras for data capture, instruments that have the ability to understand whether they're on or off, lights and cameras. These kinds of things are more common among many of our settings than they are uncommon in neurosurgery. More broadly, there certainly are difficulties in getting camera-based technologies into other procedures, but this is an area where we all want to see and grow for a lot of the reasons that Dr. Shabani mentioned, that some of these minimally invasive procedures have lower risks of problems like infections or other complications, adverse effects of surgery that can be difficult to manage with limited surgical resources. So what the challenge that we want to approach in this project is, how can we understand the information about the procedures that we're already performing and find the valuable insights within them? We know that there are millions and millions of hours of surgery that are recorded every single year or could be recorded, but it's very difficult to figure out what, if anything, we should do with this data. And I think opportunities that we have today in Tanzania and in other countries show us a large opportunity that we can take advantage of, and a critical way that we can use some technology that we've already developed and technologies that we are developing in our NIH-funded work and other work that we're doing to help understand surgery better. What we fundamentally do is we connect surgeons and computer scientists around their visual data. We're creating one of the largest repositories of surgical data in the world across many different procedures, not just ETV, CPC, not just neurosurgery, but those are certainly where our heart is. And we can identify meaningful moments within the surgery, identify differences between how different surgeons operate, and ultimately, with the help of our partners, understand how those differences relate to the critical factors of outcomes, of infections, of procedure failures, of who could get a different procedure in the first place based on their preoperative characteristics, or maybe a surgeon should have changed course during the surgery. Those are all procedural factors that we're interested in studying in part of this collaboration. The interesting thing about how this operates, I think, is it fixes and has the opportunity to repair some of the missing links in the surgical training system worldwide. Many of the difficulties and the root causes of why there are few surgeons in particular geographies have to do with how surgeons are created in the first place. And I want to commend our colleagues in Tanzania and in many other countries in Central, East, and Southern Africa for making incredible strides and making incredible progress to go from 0 to 0.1 in surgical training. But we need a bigger step. We have challenges. Surgeons have to learn in person. They can only typically learn from one apprentice and one trainer. There's no way to do long-term feedback of training. It's a one and done event. And many technologies are not ever brought to this market, even though they could make an impact. So we view that this technology could provide not just a rate step increase in the number of trainees who are trained, but actually a qualitative increase in what training even means. And the last point on this slide, I think, is particularly important. As Dr. Shabani and others have alluded to, there are more procedures of certain types being done in the low and middle income setting than in the high income setting. And that's true today for ETV CPC. That will be true tomorrow for even more procedures. It's critical that we not only share our insights from the high to low income setting, but we actually provide a way to do horizontal data, information sharing between other areas within an LMIC, as well as from the low, middle to the high income country setting. In fact, there are already programs that recognize this by sending some particular groups of high income country surgeons to actually learn and train in the low and middle income country because of the unique patient population and challenges that are seen there. So I think that's recognizing a core kernel where there's tremendous knowledge, experience, and practical utility that's being created every day in the low and middle income country setting, and it's incumbent upon us to find and understand those insights. So what this research will look like at its end state are things like access to state-of-the-art computer vision and artificial intelligence models that help turn many, many, many hundreds and thousands of hours of surgical video into quantitative reports, into very brief snapshots of what happened during a procedure, and help us understand what are the things that happened during this procedure that relate to the outcome. Did the ETV stay open? Did the patient get an infection? Were there other factors we should have seen on that video that would have told us, hey, this is actually a patient that we need to keep close to the hospital for the next 2 or 3 weeks? These are all of the critical keys that are in an ETV video. And if we broaden our aperture to aneurysm surgery or spine fusions or procedures out of neurosurgery, orthopedic surgery, or maxillofacial surgery, general laparoscopic gynecologic surgery, these are increasingly critical insights to extract. To take this home, what this actually looks like today at a small scale with a single NGO is our partnership with NeuroKids, which is Ben Worf's NGO that trains mentor-mentee pairs one by one throughout the world and is rapidly scaling up. This could look at an even greater scale. The fundamental technology we're using to help train the NeuroKid mentor-mentees will work whether there's 1 surgeon or 10 surgeons or 1,000 surgeons, all using the same platform. So we think that by working through the Tanzanian Neurosurgical Society and the Ministry of Health, we can gain greater acceptance of this technology and increase the number of neurosurgeons that we can train and other surgeons outside of neurosurgery as well. It's critical to mention that we're working in general surgery and head and neck surgery and other areas that are doing camera-based procedures, even currently. So I want to share a little bit about what we've learned and how we come up with these insights. We actually use videos of expert surgical procedures to understand best practices, including Ben Worf's own videos. And we develop analytics that can be reported back to surgeons and have already been used in the larger setting and more than thousands of hours of surgical videos, and in the smaller setting for a few hundred videos of ETV procedures so far. We think that this technology addresses the root of the problem by providing increased expertise, making that expertise globally available, again, both from high to low, middle, and vice versa, in a reverse translation paradigm from low, middle to high income country settings, and to improve the rate of training of surgeons. We're excited to build out this surgical video analysis pipeline, and I really look forward to what we can report on this next year. I'm going to pause there because I think that there are a couple of questions from the chat, and we're happy to take those. So I think 2 questions. The first question is, how can we train non-physician providers? This is an area that's extremely interesting and important. It could be that neurosurgery in some ways might be the last area where non-physician providers come to provide neurosurgical care. However, the overall provision of care by non-physician or specifically by non-surgeon, provision of surgical care by non-surgeons, I think is a better way to put it, is already occurring every single day. It's dependent on which country you're in and which practice setting you're in, but this is already part of the framework. What I'm very interested in from a technological standpoint is how can we continue to train those folks outside of the existing paradigm of come for a few weeks, come for a year, do an observership apprenticeship, but how can we help them continue to refine their skills? And I think that for video-based procedures, or when video can be captured, even in open procedures, this kind of technology provides a unique medium for that. For folks who are interested, I think we'll provide some contact information at the end of this, but we certainly encourage anyone who's listening into this webinar who's inspired to potentially join this work. And we certainly welcome the collaboration with other institutions, other countries, and with folks who are in our immediate area or throughout the US. Sorry.
You want me to
Yeah, sorry. So I'm going to pause there and we'll transition over to Dr. Singer. I'll take this one last question because I think it's directed at this. Yes, so I think the next key step and where we're very excited in going is to provide these analytics back to surgeons to accelerate their training. And one key way to do that is to understand the relationship between the surgical steps that are occurring and the ultimate outcome of the procedure, and to look for patterns and signatures of ultimately successful or unsuccessful procedures. And that's the ongoing work. I think if we could provide surgeon an insight saying this procedure is, 70% likely to work, not just from the preoperative success score, but actually updating that into an intraoperative success score, we think that there's significant value there. And the second is to show surgeons how their procedural skills are improving or changing over time related to their peers. And again, a confidential and private and secure manner, but to help surgeons understand where they could reach for, where they might even be able to improve that they didn't recognize, and to show innovative techniques that they may not have seen. So there are many ways to perform any given procedure, and I don't presuppose to know which one is the best or not, but I think that if we can show a diversity of similar procedures, but with very different steps, I think that could be very interesting. And regarding accessing the technology in MOI, this is an ongoing collaboration, and we will certainly bring this to you. And I'm happy to have specific conversations with the MOI team that we've already started. We're very excited for this. Thank you all.
So as we wrap up, I wanted to just talk about briefly where we are with our collaboration with MOI. So GW is proud to have a long history of global neurosurgery work, whether it's been publishing on some of the work that's been mentioned today about folic acid, or most recently with this month's issue of Neurosurgery, which is the leading journal in our field, which is dedicated specifically to global neurosurgery. And that issue was edited by Dr. Rosseau, something worth reading for any interested in global neurosurgery topics broadly, but also learning a little bit more about what's happening here at George Washington. Where we are right now is we're gathering the first of that surgical video. We are working through the ethics pathway, and we're designing our different projects. Some of those projects involve analysis of multiple different types of surgical procedures through surgical video, whether it's tumor, cyst, aqueductal stenosis, certainly myelomeningocele repair. We are also using that to build a repository of surgical video, which does not exist anywhere for this type of work. There's no global neurosurgical video database that exists. And so ours is going to be the first of its kind. Getting these projects off the ground takes time and effort, and having the support of the GCCA has been essential for helping build it thus far. And we've come a long way even to establish this collaboration, get the early work done over the past 6 months. We're very much looking forward to next steps. Part of this is based in the design thinking philosophy of going through and trying to understand needs and gaps and limitations. So some of the early work also involved understanding what is the literal infrastructure around internet and storage capacity at MOI, and how do we make sure that we support that and bolster that. And so a lot of this is going to be uploaded to different servers that we have through SDSC, but also sharing surgical video from off the MOI network with SDSC. So with that, I want to thank everybody for their thought and enthusiasm. I'll turn it over to Dr. Rosseau to wrap us up.
Well, great. I've really enjoyed the last presentations. Thank you so much. There are some questions regarding where we will host and store the videos. I'm going to refer you all to the SDSC website, which is just an absolutely wonderful place to get more information about Dr. Donoho's NGO. And then we also have our own website, our own page on the GW School of Medicine website, which is gcca.smhs School of Medicine and Health Sciences .gwu.edu. So that's gcca.smhs.gwu.edu. If there are any other questions? Let's see. The next step on the roadmap is a question I see from Wasim Samir. See, the platform currently uses and analyzes tool appearances. Well, next steps are, as Dr. Donoho said, to share this information with one another. First of all, for the practicing physicians, so that one can improve one's own performance against oneself, one's peers, and the rest of the world. So it's for sharing and improving knowledge and ultimately improving the way we do these procedures overall. So with that, let's go to our final slide. And let me tell you about some of the exciting things that are coming down the pike for the Global Clinical Care Alliance. So on December 4th at noon, we'll have my co-founder, Dr. Kate Douglas from the Department of Emergency Medicine, who will be moderating a webinar on care systems development, lessons from around the globe. And she and her colleagues, Camilio Gutierrez and Tanya Aluwalia, have exceptionally broad experience in this area. And then look for on our website, which you see there, for the quarterly webinars, which we plan to have next time around next year, as well as additional activities that will be part of this wonderful new bicentennial initiative with the global GW Global Clinical Care Alliance. Again, I want to conclude by thanking Dean Bass, all of my colleagues who presented this, and Ann Banner and John Carfagno, who are our colleagues here at GW, who help us get the word out about the importance of doing all we can together across disciplines to bring access to quality surgical care to everyone, everywhere. You can register for the next webinar series there. And with that, any final words, anyone? Thank you all very much. This webinar has been videotaped and recorded, and it will appear soon on our website as well as on YouTube. Thank you all, and goodbye.